Hyperkalemia means potassium is more than 5. The first question is why hyperkalemia is dangerous? Because hyperkalemia is cardiotoxic and it can cause EKG changes such as increased PR interval, peaked T wave, and QRS widening. And these EKG changes may cause bradycardia and ventricular tachycardia. This is why we care a lot about hyperkalemia and we like to treat it very early. Also, it's very important to know that hypokalemia is as dangerous as hyperkalemia. If you look at the mortality rate potassium relationship curve, you will find it's a U-shaped, means the lowest mortality here in normal potassium level, but if you have hyperkalemia or hypokalemia, the mortality increases. This means hypokalemia can be as dangerous as hyperkalemia. So this was our first question. Our second question is, what are the causes of hyperkalemia? What are the causes? So the causes of hyperkalemia can be summarized in 4 big families. First thing, you should understand that most of the potassium is intracellular, and the serum potassium or extracellular potassium is just 2% of the potassium, and most of the potassium is intracellular. So if you have cellular destruction, this can cause hyperkalemia because the potassium will go outside the cell. So this can happen in rhabdomyolysis, it can happen in hemolysis, it can also happen in tumor lysis syndrome or any other cause that can cause cellular destruction. Also, potassium shifting outside the cell can cause hyperkalemia. How the potassium will shift from inside to outside the cell? If there is increased acidosis, metabolic acidosis, and there are a lot of hydrogen ions outside the cell, so the hydrogen ions will go inside and cause intracellular acidosis, and as a reflex, potassium will go outside to keep the cell neutral because positive ions enter the cell, we need positive ions to get out of the cell. And osmolarity, high osmolarity. So if there is high osmolarity, the water will get out of the cell because outside the cell is very dry, and the potassium concentration will be relatively high inside the cell, and this will induce the potassium to get out of the cell. So acidosis or high osmolarity. So if the potassium can shift outside the cell, hyperkalemia can happen. So acidosis alone or high osmolarity alone is a cause of hyperkalemia. And the third cause is increased or decreased renal excretion. What does this mean? So most of the potassium, 97% of the potassium will get out through the kidney. So if you have any kidney injury, this will disrupt potassium excretion, and your potassium will increase in the blood. And also, in some situations, if you have steroid insufficiency or decreased aldosterone, this will impair potassium excretion. So if these are the collecting ducts and the blood is here, so usually there will be in the collecting duct sodium and water reabsorption and potassium excretion, and this is induced by steroids and aldosterone. So decrease aldosterone or decrease in steroids will decrease potassium excretion. And of course, some medications can cause hyperkalemia. So cellular destruction or shifting outside the cell or decreased renal excretion. We will talk in detail about the medications. What are the medications that can cause hyperkalemia? Medications that can cause hyperkalemia are classified in 3 families. And most of this medication will act on the aldosterone. We mentioned if this is the urine and this is the blood in the collecting duct, sodium and water reabsorption and the potassium excretion is managed by aldosterone and steroids. So any medication that can affect aldosterone will increase potassium. So if you have the medications that can cause aldosterone production decrease, such as ACE inhibitor, lisinopril, or ARBs, such as losartan, or NSAIDs, such as ibuprofen, or heparin. All of this medication decreases aldosterone production and may induce hyperkalemia, because it will, if there is decrease in aldosterone or steroid, this will affect the potassium excretion in the urine, and the potassium in the blood will be high. And also some medications that act as aldosterone antagonist. The most common one is spironolactone, can cause the same effect. Also, any drugs that causes sodium potassium ATPase inhibitor. If any drug acts as sodium potassium ATPase inhibitor, it will cause hyperkalemia. How? If you have a cell here and you have sodium potassium ATPase, and this exists in cardiac muscle cells and also in musculoskeletal cells. So you will have here one of the cells. So this is sodium potassium ATPase. So how this channel works, it uses one ATP to get one potassium inside and one sodium outside. So because it moves the potassium against the gradient, so it needs energy. This is why it uses ATP, because the concentration of potassium inside the cell is higher, so I need energy to get the potassium inside the cell. So if I block this one, I am not able to get the potassium inside the cell, the potassium will be high outside. So these medications include 3 medications, and these medications are digoxin, can cause sodium potassium ATPase inhibitor, beta blockers, such as propranolol, and of course calcineurin inhibitors, such as tacrolimus. So all of this medication So these are the medications that can cause hyperkalemia. So any medications that decrease aldosterone production or act as aldosterone antagonist or inhibit sodium potassium ATPase. So after that, we will talk about the treatment of hyperkalemia. So the treatment of hyperkalemia consists of three main approaches. The first one is myocardial stability. So I have hyperkalemia, there is a risk of arrhythmia, and my goal here is not to lower the potassium level, but to improve, to prevent arrhythmia from happening. One of these medications is calcium gluconate, and the other one calcium chloride. Usually we like to use calcium gluconate. We give 1 gram calcium gluconate and repeat every 5 minutes if the EKG are still there and the potassium is still high. Calcium chloride, we give calcium chloride only in cardiac arrest because calcium chloride has more calcium in it and can be irritating to the veins, so we don't like giving it in non-life threatening conditions. The second treatment is shifting potassium inside the cell. So we can give some medications that shift the potassium inside the cell, including insulin. But if I give insulin alone, it will cause hypoglycemia, will lower the glucose, so we should give dextrose with it. Also, you can use beta agonists because the beta agonist will stimulate sodium potassium ATPase and bring the potassium inside the cell. The easiest way, and also it's a safe way to give beta agonist, is albuterol inhaler. And the last one is sodium bicarb. There is no strong evidence of giving beta agonist or sodium bicarb to decrease potassium level. Theoretically, physiologically, it should work, but there is no strong evidence. So, but the one that really shifts the potassium inside the cell and works effectively is insulin. Beta agonist can help, sodium bicarb can help because it treats acidosis or decrease the hydrogen ions outside the cell. So this will bring more hydrogen ions outside the cell, and as a reflex, the potassium will go inside the cell. But this one is okay, but really the reliable one is the insulin. The third way to treat hyperkalemia is removing potassium. So potassium removal. And potassium removal can be achieved through 3 ways. Through the kidneys by giving diuretics, especially if the patient is hypervolemic. Also through the GI by giving GI potassium binders like Lucilma, or through dialysis. And we use dialysis to treat hyperkalemia in some situations, including if the potassium is high and refractory despite medical treatment, and significantly high, causing EKG changes, causing life-threatening condition. The only exception for the treatment of hyperkalemia is digoxin toxicity. Digoxin toxicity can